started.
Okay.
Okay. I want to welcome everybody to the fourth of our 4 sessions for our webinar series this fall. And, you know, we had hoped back in the spring to plan this event in coordination with our genetics colleagues and gynecology colleagues and our breast team. And we wanted this to be in person in 2 different sessions, but since we've done everything virtual lately, we changed this format to a virtual series. So this is the final of 4 weeks, mostly focusing on hereditary breast and ovarian cancer. I want to thank everybody who's participated and joined so far. These have all been recorded and will also be available on the Smilow Cancer Center website so that you can share them with your family or watch them later if you want to go back to them. So this week, our topic is fertility, sexuality, and menopause. And I'm going to start by introducing Dr. Patrizio, who is a board-certified specialist in obstetrics and gynecology, reproductive endocrinology and infertility, andrology, and also has a master's degree in bioethics. He is professor of OBGYN at Yale and director of the Yale University Fertility Center and the Fertility Preservation Program. And so he will be talking about fertility options for women with breast cancer and ovarian cancer genes. So thank you, Dr. Patrizio, for joining us.
Thank you, Johanna, and thank you everyone that is participating in this virtual opportunity to see. Unfortunately, we cannot see each other, but I hope my voice comes clear through the internet. So what I'm going to do in this talk, I'm going to cover the epidemiology of breast cancer, and particularly I pay some attention to the breast cancer genes that are known, and assess some key risk factors for the damage that chemotherapy and radiotherapy can produce on ovarian physiology, therefore ovarian toxicity. Then I'm going to briefly go through the various options that are available to preserve fertility and the testing that now we can offer to detect mutations in the breast cancer gene when embryos are formed and they are stored for future reproductive options. That is called the pre-implantation genetic testing for cancer gene mutations, or PGT-M. So first of all, we talk about fertility preservation. What is it? It's that process of saving, protecting eggs, sperm, embryos, or reproductive tissue from for the possibility that a person can have a biological child in the future, because infertility can arise when there is a surgery, radiation, chemotherapy, or other medical intervention that can affect and disrupt the normal function of the reproductive organs. So just to give you an idea, in the United States, every year,
I think we lost you, Dr. Patrizio.
Dr. Patrizio, yeah.
I think you're frozen.
Oh, no.
We'll give Dr. Patrizio a minute to get his connection back. Oh no. While we're waiting for Dr. Patrizio to join us again, hopefully he'll get his connection back. Well, welcome everybody to the sessions. And again, I want to say for anybody who's just joined, we have 3 other sessions that are available and recorded on the Cancer Center website. I can send you the link if you need it. The first session was an overview of the genetics of hereditary breast and ovarian cancer. The second week was Dr. Hofstetter and Dr. Ratner reviewing the breast and ovarian risks and prevention. And last week was a little discussion about pancreatic cancer, other cancers, prostate cancer in men, and also the breast reconstruction options with plastic surgery. So if you missed any of those, feel free to reach out. I can send you the link or you can find it online. And hopefully we'll get Dr. Patrizio back in just a minute. But if anybody has any questions during the session, you can type it into the Q&A box below. And we'll be right back with you. Okay, we have a change of plans. Dr. Patrizio said there's a blackout in Guilford, so he's connecting to his generator. So I'm going to take over and then he'll join us at the end, hopefully. So I will do that, and then when Dr. Patrizio can join us, he'll join us again. So I'm going to share my screen here. Give me 1 minute. It's always something. All right. Can everybody see this? Hopefully you can see this. Dr. Minkin, can you see my screen?
Lovely. It looks beautiful.
Okay, so if anybody has kids in the room or anybody that they want to kind of step away from, I'm going to do a little bit of sensitive discussion here. We're going to talk about sexuality. If you want to pour a glass of wine, please feel free. And what I want to share with you is that, you know, Yale has a particular program to talk about sexuality, intimacy, and menopause. And this is for cancer survivors and also for cancer previvors. So our BRCA patients who struggle with menopause symptoms or have any challenges with sexuality, you can certainly feel free to reach out to us at the SIM program. The SIM program is made up of gynecologic oncology team, myself, and one of our fellows. Dr. Minkin is our gynecologist and menopause specialist. And we also have psychology fellows who join to talk about the psychologic challenges that come with being a survivor and or a previvor. It's available to any females. We do have a similar program for males that's in the Department of Urology, but we are open to any female cancer survivors or previvors, and we host 2 sessions per month at Smilow. So I'll share with you a little bit about, cancer survivorship. There are, a survivor is anybody who's been diagnosed with cancer, whether it's from the day of diagnosis until the day of death. A co-survivor is somebody who's cared for a loved one with cancer, and a previvor has a couple of different different definitions, but the one I like is a survivor of a predisposition to cancer but do not have a cancer. So looking at over 2,000 cancer survivors, so we see many, many people, and many of them have the same challenges. And if you look at the little stars that I made here, the gynecologic organs, prostate cancer for men, breast cancer for women, uterine cancer, and ovarian cancer are some of the top types of cancer that people survive. There are a lot of themes that come along with cancer survivorship, and they can be both positive and negative. There are some feelings of pride and empowerment, feelings of kind of having a new identity, belonging to a new group of people. But also there's some anxiety, there's fear, relationship challenges, feeling disconnected from non-survivors, the financial challenges, the post-traumatic stress, but also a little bit of post-traumatic growth. So some people really, grow from their cancer challenges, and some people really struggle with them. So there's a lot of different themes. But what I want you to know is that the American Cancer Society feels that quality of life is very important for survivors, and that includes healthy relationships with family members, including intimacy and sexuality. So this is really part of the American Cancer Society, and it's part of our guidelines as providers that we should be addressing sexuality for all of our cancer patients. And if we focus on cancer previvorship, there's a lot of similar emotional consequences. And the family dynamics that can come with having some of these genetic predispositions, like the BRCA genes, can become really complicated. A lot of themes that are unique to previvors can be feeling rushed to complete childbearing, trying to deal with your insurance, multiple appointments and specialists to manage all of your cancer risks, considering having surgery when there isn't and there may never be a cancer, feeling grief because you're losing your reproductive and sexual organs, feeling a little bit of survivor guilt, feeling relieved that you may never have cancer, but feeling sad about the people in your family that did have cancer or maybe died from cancer, being scared of your own health, being scared of having cancer, and being scared of your children's health. Stress in the marriage. What can this cause for the marriage? Does one partner not understand what the other is going through? New identity and meaning, and also a sense of gratitude. So when we talk about sexuality, we're not just talking about penetrative sex. We're talking about any type of sexual activity, any type of intimacy, whether it's hand holding or cuddling, all the way up to different types of sex. We also think about sexual function and sexual identity. So sexual health, defined by the World Health Organization, is a state of physical, mental, and social well-being in relation to sex. So the ability to be intimate, to communicate to your partner about your sexual needs and desires, and to maintain sexual function and obtain sexual fulfillment. And there are different categories of sexual dysfunction that I won't go through. They're actually for any people who have sexual dysfunction. There are desire disorders, arousal problems, orgasm problems, and pain. But when it comes to cancer, there are so many different themes that can cause challenges with sex. There can be stress in the relationship. There can be challenges with fertility. There can be body image changes, a loss of femininity. There can be depression, fatigue, anxiety, changing roles. And this is a big one where the sexual partner is now kind of helping to take care of somebody who has a cancer and is becoming more of a caregiver than a sexual partner. Fear of rejection, vulnerability, and embarrassment, and feeling that your erogenous zone that used to be a huge sense of pleasure may now be associated with some pain or some trauma. The physical changes that our cancer survivors may go through include loss of sensation, scarring, lymphedema, where you get swelling of the arms and legs from surgery, pain, decreased range of motion or flexibility. Some people have medical devices like breast implants or portacaths for their chemo, hair loss, weight changes, problems going to the bathroom, and side effects for medications. And then you have hormone changes. So in our women, particularly, Dr. Minkin will talk about this shortly, the hormone changes that come with either chemotherapy-induced menopause or surgical menopause or radiation-induced menopause can lead to a decreased libido, difficulty becoming aroused, difficulty having an orgasm, pain with sex, vaginal dryness or tightening, difficulty sleeping, hot flashes and night sweats, and these can all cause a lot of problems in somebody's sex life. So what the research shows is that we as medical providers are not good at asking about sex. And there's a lot of different reasons for that. It could be because we don't feel comfortable, we don't have time during your appointment. If it's a cancer visit, we're so focused on your cancer and your physical health that we don't stop to ask about your emotional health or your relationships. And we may not want to make you feel uncomfortable. So we don't want to bring it up. And sometimes we know that you don't want to bring it up either, but we do know it's an important part of your life. It is okay to talk about it. And actually your provider should be asking you about your intimacy. And that's guideline driven. We are supposed to ask. And we know that partners often share concerns with you. So what do we do for people who have trouble with their sexual life during cancer treatment or as a previvor or a survivor? Well, what we need to do is we need to educate you. We need to talk about the side effects. We need to talk about what chemo might do, talk about what our surgery is going to do in regards to your hormones and in regards to your body changes and how it can affect your sexuality. And once you have any of those side effects, we need to validate you and explain to you why it's happening so that you understand and we can manage it. We certainly feel like a lot of this is emotional. So we also rely on our psychology colleagues to help us with this, but we can often recommend cognitive behavioral therapy, sometimes sex therapy with your partner. And then in the sim clinic, what we do is we talk about different therapies for different problems. So with things like lubricants and vaginal moisturizers for dryness, vaginal dilator therapy for vaginal tightening, some medical devices, which we'll show you later, and pelvic floor physical therapy. And then we can also do some prescription and over-the-counter medications. We can do some herbal remedies for hot flashes and night sweats, hormone therapy, antidepressant therapy, which can often help with hot flashes and night sweats as well. And we can refer you to different people in the community who can help you with some of these challenges as well. But it really takes a team. So you and your partner are in the middle of this circle, but it takes a team from gynecologic oncology to psychiatry, your social workers, a sex therapist, reproductive endocrinology to help you with fertility challenges, the genetics team. So lots of people involved, but really you and your partner need to be at the center of this, and we need to help you navigate this. So our psychology colleagues help to talk about the grief and loss, feeling anxious, how to cope with dating and communicating with your partner about sexuality and intimacy, any conflicts that arise and helping you to manage those conflicts, and how to embrace some kind of new normal in your intimacy. So this is an interesting picture. I really like this picture. It's actually from the American Cancer Society, and this is to get people thinking out of the box a little bit. And unfortunately, after cancer therapy or surgery, you may realize that the way you've always done something isn't the way that you can do it now. It could be because you have pain, you have difficulty spreading your legs a certain way, you have difficulty with your abdomen or your breasts because you've had surgery. You may need to explore a little bit. You need to do some different positioning during intercourse. We often have our pelvic floor physical therapists help people. We recommend Kegel exercises to strengthen the pelvic floor, and just kind of experimenting and trying new things. A lot of this is about communicating with your partner. Sometimes we recommend a sex therapist to help with sexuality concerns and also just focusing on the psychological part of sex. So there's also a way to find a sex therapist if you're interested. And what Dr. Minkin is going to go into as well is some of the medical interventions. So these are some of the things that we recommend for our women, different brands of lubricants and vaginal moisturizers. Sometimes we use estrogen creams or estrogen suppositories for vaginal dryness. On the top left, what you'll see is something called the O-nut, which is actually some stackable rings that can be put onto the penis so that the penile depth is not as deep in penetration. So if you have a little vaginal shortening from surgery or radiation, that the penetration won't be as deep and it won't hurt you. Lidocaine jelly is very good at the opening to the vagina, especially if you have pain right on entry. And then on the right there, we have a vibrator, which can sometimes help with some stimulation, but also bringing some blood flow to the pelvis. And in the bottom there, those are the vaginal dilators that we often recommend. And what the vaginal dilators do are they slowly stretch vaginal tissue. So if you have any problems with tightness of the vagina, you can over time stretch the tissue so that it can be a little bit more elastic. So these are some of the things we talk about in our sim clinic. And then we often give hormone therapy, and Dr. Minkin's going to go into this, so I won't spend too much time here, but in previvors, we know that menopause hormone therapy can be very safely used. Some cancer survivors can also use hormone therapy depending on the type of cancer they've had. So we often use vaginal estrogens for vaginal dryness, and we use either these little patches that you'll see or pills for hot flashes and also for health, keeping your bones strong and preventing osteoporosis, keeping your heart healthy, preventing heart disease, keeping your brain functioning well, that's your cognition, helping you sleep, and of course, the sexual function. So I'm just going to talk briefly about the different types of cancer. So in breast cancer survivors, you know, these people are all ages, all stages. You know, we see our breast cancer survivors from their 20s up until their 80s and 90s. And the problem with breast cancer treatment is that it really is multimodal and it impacts sexuality in 5 different ways. You know, radiation can cause pain and scarring and fatigue. Surgery and breast reconstruction can cause difficulty with sensation, body image changes, and pain. Lymphedema. Chemotherapy, of course, can put you into menopause and can cause a lot of side effects. Endocrine therapy, and that's either the tamoxifen, Arimidex, the aromatase inhibitors, anastrozole, exemestane, Femara. Those are some of the medications you may have heard of. Those can cause a lot of additional hot flashes and night sweats and vaginal dryness. And ovarian suppression, and that's when women get shots of medication to shut down the ovaries to stop making hormones. And so in these patients, you really are hit from all angles. And so we try to do mostly non-hormonal management of your side effects, but hormone therapy usually is avoided. In our ovarian cancer patients, the challenge is that there's a big surgery involved. And chemotherapy can be prolonged. There can be a long recovery time. And really with ovarian cancer, we tend to be very focused on survival and quality of life. And we don't often think about the sexuality piece with ovarian cancer, but we really should. We want people to have a good sex life. In some patients, hormone therapy is actually okay with ovarian cancer. We always talk to the oncologist about that. And then we have our lovely previvors, and we love taking care of the previvors because we often get to walk them through from ovarian cancer surveillance and prevention to eventually having perhaps breast surgery or ovarian surgery to prevent cancers. And then we have to try to help you with menopause because a lot of women are young, married, may have young children and have this big emotional challenge, and then they go into this abrupt surgical menopause. And nothing was wrong at first. And now they feel like my body is all messed up and I never had cancer. But we say, well, now you're never going to get cancer. But there's a lot of difficult decisions. Do I do breast surgery first? Do I do ovarian cancer surgery first? Do I do both at the same time? And what we know from the literature, specifically in our BRCA mutation carriers, is that for the most part, the vast majority, 97% of women are satisfied with their decision to have surgery and they report a good quality of life. But that doesn't mean their sex life always comes back to how it used to be. So the theme that we know in the literature and what we've seen is that for the most part, people are very happy, but sex may look a little bit different after this type of surgery. So what we like to do is really shared decision making. This is all about you. This is about us giving you options, educating you on what we can do, and then letting you ultimately decide how you want to be treated. We certainly focus on psychotherapy and emotional support, and we try to focus on what intimacy is like for you and for your partner. We love to have partners come to these appointments. We'd like to have an open dialogue with the partner so the partner understands what you're going through, and also that you understand that your partner is certainly worried about you as well. Dr. Minkin is going to shortly talk about hormone therapy, but I do want to share with you briefly that after risk-reducing oophorectomy, that's taking out both of the ovaries and fallopian tubes, taking hormone therapy to supplement what your ovaries were doing does not further increase the risk of breast cancer, even if you keep your breasts. And that's pretty much standard. Now, there's no large studies. There are no long-term studies. The studies have been in relatively small groups of women because we know that the BRCA carrier population is not a huge number of patients, but the studies that are out there do show that systemic hormone therapy, either a pill or a patch, and vaginal hormone therapies are very safe in our previvors. And really, they are recommended. You know, they're helpful for your quality of life. They're helpful for your your bone health and your heart health. And you need hormones. Hormone therapy, however, may not cure all menopause symptoms, so we can help you in the other ways. And Dr. Minkin is going to share more with you about that. And here's one of the latest articles I just wanted to show you. This is a study of 159 patients. And the study is about hormone therapy after risk-reducing salpingo-oophorectomy. That's removal of both ovaries and fallopian tubes. And is it associated with an increased risk of cancer in mutation carriers? And so this was just published actually this year. And it was in 5 different cancer centers, 159 patients. And the result was that there's no increased risk of any type of malignancy. There were a few cancers in both of the groups that had hormone therapy and the groups that didn't. There were a couple of, about 6 cancers in each group, but there was not a difference whether people had hormones or did not. And I think that's really important for you to know, because women in their 30s and 40s really need to have hormones for their quality of life. So being diagnosed with a cancer or a predisposition to cancer, having cancer therapy, and even having prevention for cancer can have long-lasting impacts on your sexuality, but we are here to help you. We can help you with the physical changes, the hormone changes, and the emotional changes, and it's okay to talk about sex with your medical team. It can get better. There are lots of resources out there, and a couple of different resources I have here. Dr. Minkin's website is right here. It's called Madame Ovary. I'll let you look at that on your own at some point. She's got some great videos and podcasts that she can show you. You can see her blog. The latest podcast is the new podcast that she'll tell you about. Another really nice website, I don't know if I can get to this one, is called Force. And Force is Facing Our Risk of Cancer Empowered. So Force is about hereditary cancers. This is a great website that you can go to get involved, get updates, learn more, and get support about hereditary cancers. And then the last one I want to show you is the Hereditary Breast and Ovarian Cancer Society. That's a nice organization as well. And you can look at this. It's about being a previvor, about the society, you know, getting involved, getting some help, and learning more about being a cancer previvor. So a couple of nice resources. The American Cancer Society has an entire section about sex after cancer for women and men. There's the Sexuality Educators and Counselors website. The North American Menopause Society has menopause information, and there's also the Foundation for Women's Cancer. So if you have any questions, if you don't have time to scribble these down, I'm happy to send you my slides or send you any of these resources for yourself. And with that, I am going to thank you. This is my email. Feel free to email me. Feel free to call me. And we'll try to shift back and talking about fertility. I would love to take questions at the end, but I'm going to turn it now back over to Dr. Patrizio. So Dr. Patrizio, you're up. Welcome back. I'll let you share your screen again.
Thank you, Johanna. Let me share. We had a completely blackout in Guildford, so the generator kicked in. Okay. Can you see the slides? Yes? Okay. So the talking point, epidemiology of breast cancer and breast cancer genes, key risk factors for chemo, radiotherapy, toxicity on the ovary, and the options that are available to preserve fertility. And then at the testing, the pre-implantation genetic testing, PGT, to detect cancer gene mutations, even in an embryo, if one of you is found to be a carrier of hereditary breast cancer. So by doing testing on the embryo, we can detect whether or not that same mutations has been passed on to another generation. So first of all, the definition of fertility preservation, which is the process of saving, protecting eggs, sperm, embryos, or reproductive tissue, so that a person can use it in future to have his or her own biological children, because surgery, radiation, chemotherapy, or other medical intervention may impact the reproductive organs. Every year in the United States, there are about 70,000 women that they are diagnosed with the cancer in reproductive age. So we talk about women up to the age of 44. And of these 70,000 cases per year, the bulk, the majority, are women with breast cancer. They represent about 15% of women that have a breast cancer. They get cancer in reproductive age. So about 45,000 women per year. Now, the genes that have been mostly related, detected in breast cancer are the BRCA1 and 2, and then a series of others, the partner and the localization of the breast cancer 2, the checkpoint kinase 2, the PTEN, and so forth. The reason why it's important to know if someone is impacted by any of these hereditary conditions is because these cancer genes, we are defining them as actionable with the PGT mutation testing. So if we know that the patient has a mutation, and that's the likelihood reason why she got the breast cancer, now we can test the embryos and find out whether or not that mutation is present in the embryos that we want to use for future reproduction. In terms of frequency of the most common one, the BRCA frequency in unselected non-Jewish population in the United States, this mutation impact 1 every 400 women. In Ashkenazi Jewish, unselected, 1 out of 40, meaning that 1, and also 1 out of 3 has one of the 3 most common mutations that are listed here. These are the 2 for the BRCA1, and the last one is the founder mutations for the BRCA2. When you look at the incidence of cancer risk per decade of life, if someone is a carrier of BRCA1, by age 30, the risk of breast cancer is about 3%. By age 40 is 21%. By age 70 is close to 70%. While the BRCA2 has a lower incidence in the early age, but at the end by age 70, 74% of women with BRCA2 will have breast cancer. Now, what is important also to remember and to state is that the presence of BRCA1 and 2 mutations does not mean only risk for breast cancer, but also for other type of cancer. The BRCA1 carriers, for example, they also have an increased risk of ovarian cancer. If there is a male, the risk is lower, 1% of male breast cancer for the BRCA1. However, if it's a BRCA2, the male breast cancer is 7 to 8%, and the incidence of breast cancer is 69%, and ovarian cancer 17%. But there are also other type of organs that can be impacted by the BRCA mutations. For example, we have the fallopian tube risk. That's why what Johanna was saying before, the prophylactic salpingectomy, just to remove the risk of having fallopian tube cancer, primary peritoneal cancer, and ovarian cancer. But there is also important to mention pancreatic cancer, and for BRCA2 in male, the prostate cancer, and the BRCA1 also seen in colorectal cancer. So altogether, these are important to keep into account when we do the discussion of whether or not we should offer testing on embryos to avoid the future generation to have the same potential issues for cancer. The good news, breast cancer is a very curable disease nowadays. 89% of women at 5 years, they are alive. This is a slide from statistics of 2005 to 2011. So that's a very good news. However, what is important is that part of the paradigm of quality of life is important to realize that now is crucial to talk about fertility preservation, because life goes on. More and more women are surviving breast cancer, and therefore after they've been impacted by the cancer in the early age, they want to be sure that after the cancer has been cured and they are survivors, that they can go on and have their family. The risk of menopause or early menopause is, however, impacted by the type of chemotherapy, the dose of chemotherapy, whether chemo is also associated with the radiation, and also the age of the patient. Patients that are diagnosed and treated at 35 or older, they have a higher risk of developing early menopause than compared to women that are younger, even though they will be using the same dose of chemotherapy. Here is just a very rough list on what type of dosage treatment protocols are associated with a higher risk of having premature menopause. In red, you see the one that we as a reproductive endocrinologists, we are extremely concerned that can be associated with early menopause, and that is the use of cyclophosphamide. Cyclophosphamide or alkylating agent at a particular dosage is considered high risk. Patient will go into early menopause. So if in a protocol of breast cancer or any other type of cancer, cyclophosphamide is included, we definitely would like to do and offer some type of fertility preservation. It's also important to realize that even though a woman has now survived and and her menstrual function have returned after she has been treated with the chemotherapy, we always stress that to remember that the age of menopause in women that have now resumed their menstrual function is much shorter than it would have been if there was no chemotherapy or radiotherapy. Therefore, the message is, okay, you survived, we did not have the chance to freeze eggs or freeze embryos, but try to reproduce at the earliest, because menopause will come earlier than what would have been if you were not treated with the chemotherapy. What are the options to preserve fertility? Hormonal suppression, the one that Johanna was telling you before, which are monthly injections to block your menstrual cycles. Unfortunately, the evidence is still inconclusive. But in the absence of anything else, it's always a good idea to be at least using these medications, monthly injection to suppress your hormonal function. Then egg freezing. Egg freezing, I will talk about it. Embryo freezing, or a combination of egg and embryos depending on circumstances, relational circumstances of a particular patient, and then ovarian tissue freezing. Now for egg freezing, generally this is an option that is offered to women that are single, generally younger than 42, because if they are 42, we prefer to perhaps do an embryo freezing instead of an egg freezing, although it also varies from patient to patient. We need about, there are also patients that they are in a relationship, but they still have religious objections to do embryo freezing, so they want to still do egg freezing. Sometimes they don't feel comfortable with their partner to say, no, I'm going to do embryo freezing, because they are very much afraid of leaving a burden on the partner in the event something goes wrong. He says, no, I don't want to leave embryos, then my partner has to decide what to do. If I freeze the eggs, I'm going to be much less stressed in that they are not a potential for life. And it's about 10 to 12 days to do the egg freezing, and should be always done before chemo or radiotherapy has commenced. At Yale, we have done now 101 patients. These are slides of about 4 months ago. And the majority of patients that they have frozen their eggs are patients with breast cancer, because it is the most common cancer that comes to our attention for fertility preservation, followed by lymphoma and Hodgkin and non-Hodgkin lymphoma. No patient has yet used their oocyte, so we have almost 800 eggs still in liquid nitrogen, and as of a couple of years ago, the worldwide literature documented 24 live births from the use of eggs that were frozen for cancer patients. Okay, this is just specifically for cancer patients, meaning that the great majority of eggs are still frozen in the various laboratories around the world. The most used technology, however, is the embryo freezing. But embryo freezing, you need to have a partner, or you need to use donor sperm for that. And the main stage at which the embryos are frozen, it's a stage when they are 5 days old. So they are called the blastocyst. And this is also the best time to do the embryo biopsy. So this is a typical classical blastocyst. And the way that the biopsy is done, in case that you are a patient is a carrier of a known mutations responsible for that particular breast cancer, this is the way that the blastocyst is biopsied. So this is the embryo. And you see here in this case, in this picture, I put the green cells, meaning that when we take 5 or 6 cells off of the embryo at this stage, and they come back negative with the testing that we are offering, that means this particular embryo is not affected by mutation, so it can be easily used for transfer in the future. While in this case, if the test comes back and is showing that the embryo carries the BRCA mutation, so this is an embryo that is positive for mutations. Generally, embryos are frozen after the patient has completed the treatment, with the chemotherapy, radiotherapy, then it's got to be on prophylaxis, adjuvant therapy for 2 to 3, sometimes even more years, using tamoxifen or an aromatase inhibitor. When the oncologist gives the green light, then we can use the embryo that has been frozen, or the eggs that have been frozen, and then we can use them for future reproduction. So in terms of testing, the testing is done by a test called the PGTM with the linkage analysis, which is very, very accurate in identifying if that particular mutation is present. Now the question could be, can you also do the testing on the eggs? If I don't have the embryos, can you also screen an egg for that particular mutations? And on the egg is not so easy to do, because you need to do a couple of genetic processes. So it's better to do it on the embryos and not on the egg. What are the protocols that we use to collect eggs or to make embryos? The protocol always include a aromatase inhibitor, letrozole, and the letrozole of Femara. In this way, during the stimulation, there are not a rise in the estradiol or estrogen levels. And therefore, this is going to be a very safe protocol. It takes only 10 to 12 days nowadays to do an ovarian stimulation. And we can start the stimulation at any time in the menstrual cycles. 4 or 5 years ago, we were always bound to when the patient was in the menstrual time, at the beginning of the menstrual cycle. Now this does not take any more priority. We can stimulate a woman anytime in the menstrual cycle. Even if you have just ovulated and you are in the middle of the menstrual cycle, I can still do an ovarian stimulation, 10 to 12 days, and then I collect new eggs. So this is just an example of the letrozole protocol. So in this particular case, we started the letrozole, we started the injection called the gonadotropins to make eggs, and then 10 to 12 days later, we collect the eggs. Just to give you very, very little numbers on whether it's important to do the ovarian stimulation for egg collection before or after a breast surgery, it doesn't matter. There's really no difference whether an egg collection is planned for before, pre-resection, or after surgery, because there is no difference in the number of mature eggs collected and the fertilization rate. There is also no difference, which is very important, in survival in women that they have ovarian stimulation according to the receptor status. If someone is an estrogen receptor negative or estrogen receptor positive, some women are a little bit nervous about being stimulated. It does not change the survival rate, even if they are estrogen receptor positive, because in that short period of time, 10 to 12 days with the letrozole, the 5-year survival is not impacted. So that's a good news, not to be afraid of the estrogen receptor status. Then I will also go briefly on a technique that is available for here at Yale. We don't use it too much for breast cancer, but this is a technique called ovarian tissue freezing. Okay, so these are patients that they really have no time for they don't give us those 12 days. They want to freeze just more than few eggs, because if you do an egg freezing cycle, how many eggs can we freeze? Probably 10, 12. Then we may do another cycle. We may ask the oncologist to wait another 10, 12 days before starting chemo. So we may accumulate another 10 to 12. But those are going to be just 20, 24 eggs. And for some patients, they always ask, but is this enough for my future family needs? Well, how big would you want to have your family? They say, I want to have 2 or 3 children. Maybe 20 eggs is not enough. So then ovarian tissue can be an option. What we do with the ovarian tissue? We collect ovarian tissue with the laparoscopy. This is a picture of a piece of ovarian tissue collected. Then you must know that all the eggs, you see these little dots here, they are all in the outer surface of the ovary. And therefore, this ovary has to be, this cortex, this little piece of ovary has to be made very, very thin. Then it's going to be cut in square. And then after it's been cut in square, we put in particular solution, and then it's going to be placed on this grid. And then after it's placed on this grid, it's going to be plunged into liquid nitrogen, and then it's going to be stored for wherever it needs to be used. When it's used, it's going to be used for retransplant, and it can be put back on the ovarian scaffold. If the woman went into menopause, can be put on the peritoneum inside the pelvis. And what is very characteristic is that it takes 4 months. If a woman is in menopause after the treatment, and I put back the ovarian tissue, I have to wait 4 months before she can resume the ovarian cycle. And there are many babies now that have been born from the ovarian tissue retransplant. In fact, at the last official count, there are 148 documented live births when there was ovarian tissue that was frozen and then was retransplanted in the women or pelvis. Okay, so that's good. So what I want to say is that future fertility is at risk when the breast cancer patient require chemotherapy and radiotherapy. I also want to say that it's almost impossible for anyone to predict what chemo protocol or radiotherapy protocol is better than others in safeguarding the future fertility. Therefore, in the absence of a certainty, nobody wants to take a risk and say, oh, I'm kind of going to be playing my odds. My chemotherapy protocol is going to be only 30% risk that I'm being fertile. Yeah, but who is going to take the risk? And I'm very much a strong proponent that every patient should have a fertility preservation consultation, should be given all the opportunity and information to make their decision without any risk of feeling regret for the future. And they should be made available any possible future fertility strategy. Embryo preservation could also include the test of PGT, pre-implantation genetic testing, for screening any possible hereditary cancer mutation. So this is not going to be passed on to a new or a next generation. Of all of this, unfortunately, we are still fighting, even though Connecticut was the very first state in which insurance were given a mandate to cover fertility preservation for medical reasons. We are still fighting in covering for the cost. And another hurdle is the lack of information. In other words, women are not told, except when they come from Smilow, they are not told in general that there are many options, and that's something that we are working very hard in trying to provide access to the treatment that are available. There are advocacy groups, I just listed very few here, but there are many, many more. You can take note on this on this advocacy website. You can find really a lot of information and a lot also of directions on which doctor is going to be in closer to the place where you live. And in final summary, we do have at the Smilow really a critical mission in preserving fertility. In fact, we do have a clinic that we as reproductive endocrinologists staff every Wednesday afternoon, and we do consultation right there in the cancer center, and we offer the consultation and discuss all the options that are available. So this is it, what I had to say. Thank you, and sorry again for the interruption at my very first attempt. Thank you.
That's okay, Dr. Patrizio. Thank you for sharing that information for everybody. And I agree with you. I think that it's it's not known, under-recognized that fertility is an option for women before they have any risk-reducing surgeries and to prevent the genes. So that's very helpful. And I think you'll have a lot of questions about that later. So we'll shift over now to Dr. Minkin, who's going to talk more about menopause management. And so I'll bring up Dr. Minkin's slides here. Hold on one second. Dr. Minkin, I'll drive your slides.
Thank you much.
Okay.
Ah, they're there. Okay, shall I go ahead? Okay, first of all, thank you all for joining us this evening. It's, of course, one of my absolute favorite topics, and Johanna knows that very well. And I want to thank Johanna and Pasquale for lovely talks, and I'll see what I can do here to try to keep you all a little bit entertained here. Okay, so I'm the old menopause lady, as I introduce myself to all of our patients, and I'm here to talk this evening about menopause for women with BRCA, and both for previvors and survivors. And this is some of my stuff to get a hold of me and things like that. Okay, Joanna, can I have the next slide, please? You're going to be advancing them there? Okay, all right. So can we go back? Is that that's the, yeah. Yeah, okay, there we go. Very good. Thank you very much. Okay, so anyway, basically, I'm going to divide this talk into sort of two basic parts. There's going to be parts for previvors and women who are survivors. Okay, I'm going to start by talking about previvors, who are women who carry mutations but have not had cancer but are doing preventative therapy. And in BRCA, we're talking about preventative therapies for removal of the ovaries. And of course, breast cancer, preventive mastectomies is a different area, but here we're talking about hormonal function. And part of the issues that we're dealing with are the fact that many of the women that we're dealing with are very young. I call them kiddies, and people that have gotten used to me dealing with that. These are very young women, and these women, young women, are premenopausal when surgery is done. What we do know, of course, is that taking out ovaries puts you into menopause. That's what happens. And the other thing that's sort of a well-known issue is that young women tend to have more symptoms like hot flashes when they go through menopause. So if you have somebody who's just, you know, any Jane Doe walking down the street, if she's 40 years old and goes through menopause, she's likelier to have symptomatology than a woman who's 50. Not that 50 years old, that's very young, but 40-year-olds are more likely to have symptoms. So we're dealing with young women having their ovaries taken out and having significant symptoms. Okay. However, and Joanne Johanna alluded a little bit to this, is that if you do take out ovaries in very young women, there are significant risks of not having estrogen on board. And the risks that we know very well, if people want to talk more about this, we can. There are significant risks of developing heart disease, osteoporosis, and even dementia if you basically take a young woman who's 40 years old and don't give her estrogen, compared to somebody who goes through menopause at the average age. And the average age of menopause in this country is about 51. Okay, so we know we can prevent that if we do give estrogen therapy. And as Johanna already said, we have excellent data that giving estrogen to women who are previvors is quite safe and does not increase the risks of developing breast cancer. So that's a very important thing, that we can give estrogen safely, and that we're not going to increase women's risk of getting breast cancer. So why not think about giving these women estrogen? And our usual advice, and there's nothing written in stone about any of this, is that as far as how long, let's say somebody has her ovaries out when she's 35 or 40, how long do we keep them going on estrogen? And we usually encourage women to continue to take estrogen until the average age of menopause, which is 51 in this country. Now we can continue longer, but that basically goes in discussion with your providers, your oncology folks who are following you, as far as pros and cons. But there's nothing written in stone to say it's got to stop at age 51, but that's sort of a basic guideline. Okay, Johanna, can I have the next slide, please? Okay, now, when we take out ovaries, which is what we're doing to basically prevent ovarian cancer, we're taking out the tubes and the ovaries, but we're not talking about the uterus at all. So if you are taking out the uterus, okay, that becomes a hysterectomy as well as a bilateral salpingo-oophorectomy. Okay, well, why does that? Well, who cares? I mean, what is that important? Okay, why are we talking about that in a discussion of menopause? Well, if you have your ovaries taken out, okay, and you have your uterus in place, we need to give people estrogen, of course, to replace the estrogen. But if somebody has a uterus in place, we need to give something called progesterone with the estrogen, because if we just give estrogen and the uterus is there, we can end up stimulating the lining of the uterus and precipitating overgrowth of the lining, and possibly even in some women developing cancer of the lining of the uterus. So we know we can prevent that by giving progesterone. Okay, now, so the key thing is there are certain people with different variants of BRCA in whom a hysterectomy will be beneficial, because there are a certain small group of women who are also with this particular variant of the BRCA gene may be at higher risk of developing uterine cancer as well. And in those women, we will recommend that they have a hysterectomy as well as having their ovaries taken out. Okay, but again, this depends on the exact genes. Well, what's the good? Well, why not take out the uterus? Why take out the uterus if you don't have one of these funky genes that can screw up your uterus as well? Well, if you do take out the uterus and you have somebody that you want to give hormone therapy to, you don't have to give progesterone to a woman who's had her uterus out. You just have to give her estrogen. And that has certain advantages, particularly that you don't have some of the side effects of progesterone, including vaginal bleeding issues. So that's something that we avoid by taking out the uterus. Well, why not take everybody's uterus out? Well, for example, if somebody wants to have a pregnancy afterwards, well, we can't take out her uterus because we want to leave her uterus in there if she wants to have a baby. And of course, the other thing as far as recuperation, that the surgery itself is a little longer if we take out the uterus as well as the ovaries, and the recuperation is a little longer. So these are the kinds of decisions I don't want anybody making this evening. And we can certainly talk about pros and cons, but this is one you want to really make a decision with your provider. And as Johanna alluded to in the beginning, this is truly, all of these issues that I'm talking about are truly shared decision making. There is no decision here that should be just the sole decision of your provider. This is shared decision making. Johanna, can I have the next slide? Okay. And the good news is that we should be able to control pretty much almost all of your symptoms. You may say, well, is estrogen all I'm going to need if I have my ovaries taken out? Is estrogen the one hormone that I will need? Okay. And the answer is primarily yes. Okay. In some women, we not only give estrogen, but we also give testosterone. And some people start making faces at us, and Johanna can attest to this. Testosterone, we're not guys. Testosterone is also a female hormone. The guys make more than we do, but we make plenty of it. Okay. And if somebody is experiencing a loss of sex drive, and Joanna alluded to this a little bit too, that we may want to give some testosterone as well as giving estrogen to enhance libido. We think that that's probably involved in libido for many women. And some women find testosterone helpful for things like a sense of energy and a sense of well-being, but we can do that quite safely too. But what about the other fun symptoms of menopause? Things like hot flashes, night sweats, sleep issues, achiness, vaginal dryness, bladder issues. I can go on and on here. But those all should be okay with giving estrogen. So there really aren't too many symptoms that we can't deal with by giving some estrogen and occasionally a little bit of extra testosterone. Okay, can I have the next slide there, Joanna? Okay, so we're talking a little bit in advance about the women who are the previvors who have not had cancer. We're taking care of them before cancer's had a chance to strike them. We're doing this preemptively, proactively. But what about women who've had breast cancer? Well, we do have many therapies, many of the same therapies we can give to previvors. The one thing we can't give to a woman who's had breast cancer, active disease, is we're not going to be giving her what we call systemic therapy. Their systemic therapy basically are things that get into the bloodstream in a considerable amount that can affect the whole body, okay? And those are primarily given with pills or patches, okay? There are many other options, but we have other things that we can use other than estrogen to take care of a lot of those lovely systemic symptoms that we talked about in the last slide there. Can I have the next slide, please? Okay, let's talk about some of these because some of you may have, had breast cancer and are BRCA carriers and had the appropriate surgery. Well, we have other medications and herbal products which are not estrogenic, which are very reasonably effective against hot flashes. There are several herbal products, although this is controversial. The North American Menopause Society, one of my organizations, it does not necessarily smile on non-hormonal therapy herbal remedies because they doubt the efficacy. If you look at literature from other countries, there's plenty of data out there, trust me. And one of the standards that's out there is a product called Black Cohosh, German Black Cohosh. And why am I selling German Black Cohosh here? Well, the reason I'm saying that is, unfortunately, in the United States, we don't supervise our herbal products very well. And Joanna knows I get on rants about this topic pretty regularly. For example, my standard line is I can go pick up some dirt from outside this office and tell you it's Black Cohosh and nobody could stop me. And in Germany, if you do that, they throw you in jail, which is the appropriate thing that should be done for that sort of thing. So Remifemin is a German Black Cohosh product, and it's very reasonably effective for hot flashes. There is also a Swedish product. These are all over the counter. These are not prescription, called Relazin, which is a Swedish pollen extract, and that's actually very popular in France among French oncologists. And there's also a product there's also several soy derivatives. Femerel is one of the better known ones, very popular in Europe, that is a purified soy derivative, and all have reasonable efficacy for many women against hot flashes. However, we also have some other medications that are prescription medications, which can be quite effective. And many of you know this, but some may not, is that actually SSRI and SNRI antidepressants can be quite effective against hot flashes. What's also, I always have to mention this here, because the actual discovery, though, that SSRI and SNRI antidepressants actually work for hot flashes was not discovered in women with breast cancer who we were afraid of giving estrogen to. It was actually discovered in taking care of men with prostate cancer who were being given medications which lower their hormone levels. And they get hot flashes too. And that's how they discovered the SSRIs and SNRIs work. Another drug which is very effective for hot flashes is gabapentin, or the trade name's Neurontin. And that can be very effective for women. The other nice thing, and again, a lot of these are dual purpose. So if somebody does have some element of depression, an SSRI or SNRI might be quite helpful for them as well for depression. Gabapentin happens to be a good drug for body aches and pains. So for example, if somebody's had, say, neuropathy as a result of some chemotherapeutics or something like that, we might use gabapentin for the neuropathic pain. And it also is good for hot flashes. So it's takes care of two things. Now, there is one new exciting drug that's out there that I can't tell you about quite yet, or I can't prescribe it for you. Let's put it this way. I can tell you a little bit about it. And this is a drug that actually acts in our brain. So when somebody says, oh, those hot flashes, you're in your head, that's exactly where it is. It actually starts in the brain is where this all stuff happens. And there's a class of new drugs called NK3R, or neurokinin 3B receptor antagonists. And this is really, to me, it's extremely exciting literature and experiments, because these drugs are very effective and really just about as effective as estrogen on taking care of hot flashes. So stay tuned. These drugs are in phase 3 trials right now. The preliminary data looks quite good. My guess is we're talking about 1 to 2 years away, but it's not eternally into the future. So stay tuned. They're out there. So we have good drugs, but we're going to have even better drugs at some point in the future. Now, let's talk about vaginal dryness. Thank you, Joanna. First of all, this is another very common problem for women, and the hot flashes do tend to come earlier for women, so everybody associates them with menopause. Vaginal dryness actually can occur later on in the menopause process, and it may be so much later that women don't even associate it with menopause. Okay, but the thing about vaginal dryness, we have a lot of over-the-counter remedies available for women. A couple of things most women need to have discussed with them is that there are two ways with the over-the-counter remedies. There are lubricants, which are products which can be used at the time of intercourse, and there are many, many out there. One thing, if you are buying a lubricant, I standardly say to people, please don't buy the giant economy size, because many women are sensitive to a perfume or a component of the gel, and I ask you to buy a small amount first, see what agrees with you, and then you can go out and buy the giant economy size. There are also moisturizers, which are long-acting products which are inserted vaginally. These are over-the-counter. You insert them 2 to 3 times a week, and they sort of recruit moisture into the vaginal walls. There's a couple of very popular varieties. A product called Replens has both an internal and an external product, which is over-the-counter. This is a polycarbonyl gel. You put it in 2 to 3 times a week in a preloaded applicator, and it does work nicely. Now, many women using a moisturizer also will benefit by using a lubricant at the time of intercourse. And another product that works very nicely for our patients is something called Reverie, which is available online. It's over the counter. And this is a hyaluronic acid product. Many of you may use hyaluronic acid on your face. Well, this is hyaluronic acid for your vagina. And it's quite effective for many women. Okay. And most women will try those first. However, if that's not sufficient, okay, if a moisturizer or lubricant, you're still uncomfortable, we have a lot of other products. And many of our patients get very anxious when we start talking about them, but vaginal estrogen, and there's another product, DHEA, which gets converted into vaginal estrogen, really are quite safe to use, okay? And there are actually now papers out by the American College of OBGYNs and the North American Menopause Society, which endorse the data that says, listen, that you can use these vaginal estrogens, the blood levels, and we have studies measuring the blood levels, show that there's basically no systemic levels achieved with, I won't tell you no molecules go by, but there are very few levels that are achieved with vaginal estrogen. So most people are quite happy to let women who've had a history of breast cancer use vaginal estrogens or vaginal DHEA. And these are suppositories, they're rings, they're creams, a lot of different options that we have. And if one you don't like, it doesn't make you do the problem and stuff, take care of things, we can always switch to another one. So they're there, okay? And there also happens to be a medication, which is an oral medication, which is not estrogen, and that's called ospemifene or Osphena. And it's a very interesting chemical, at least it's interesting to me, because the closest relative in the world of pharmacology out there is tamoxifen. So ospemifene is also a SERM, very much like tamoxifen, and that it acts like a SERM, so it helps protect the breast, it helps protect bone, but it also happens to moisturize the vagina, which is very nice. And we have a number of people taking that. So that's another option that we have. So we have lots and lots of options out there for women. You know, anybody has questions, we're happy to answer them, to talk about these different options that we have. Okay, can I have the next slide? Okay, and I don't want to be advertising, but Joanna did a little bit of this, so I'll do a little bit more. And we're not advertising, but come to Sims, we can help. Okay, we were actually one of the first centers that was founded in this country to deal with sexuality, intimacy, and menopause issues for pre-vivors and survivors. And now, thank goodness, we started about a dozen years ago, but there's now a much wider realization in the cancer community that there are many, many special issues that women who are pre-vivors consumers and survivors need to deal with, and we can help with these issues. And the other, self-aggrandizing thing that I'll mention here is please visit my website. It's out there for you, madameovary.com, and we have some basic videos for menopause and menopause education, and we also have a couple for cancer survivors. And now my venture into the 21st century is I now have podcasts up there. This is actually an invention of the last month here. So if you go click podcast, you can hear a couple of basic menopause podcasts and a podcast for cancer survivors. So what I'd like to do here is to shut up, because I know people probably have a lot of questions, and answer questions. And Dr. Patrizio and Johanna and I are all here to answer questions. So here we are, and please go right ahead.
Well, thank you, Dr. Minkin. I'm sorry I forgot to give you a formal introduction, but Dr. Minkin is truly a menopause guru. And if you look up, she has books on menopause. She's been at Yale for her entire career, I think, but has just done wonders in the menopause world. So at this point, if anybody has any questions to share in the Q&A box or in the chat box for Dr. Patrizio or Dr. Minkin or myself, we're happy to answer some questions for you. Don't be shy. We could talk about this stuff all day.
Absolutely, and we do. Somebody must have some questions.
Okay, here's one. The costs, Dr. Patrizio, this is actually a great question. Can you share with us the costs and whether or not insurance will cover the PGT testing for reproduction for people with BRCA gene mutations?
Yes, thank you for the question. In terms of cost for the embryo freezing first and then the PGT, the embryo freezing in itself, without if your insurance does not cover, and again in Connecticut they should cover because there is a law that they should cover, it's about $13,000-$14,000. On the top of that, you need to add about $5,000 to do the pre-implantation genetic testing for mutations. Here, the problem with the insurance, it's a much more a sticky note here, because insurance, they try not to cover this. However, if you do take a fight with them, I had a couple that were very, very adamant in taking this on the insurance, and at the end they did cover. Now, in your case, you said that it's not you carrying the mutations, but is your husband or your partner carrying the mutation. And even in this case, there is always a 50-50 chance that the embryo or your future child can have a mutation that is inherited given by your husband, and therefore there is always a reason to do the PGT-M, the pre-implantation genetic testing, even if it's your husband carrying the mutation. So the answer about whether it's covered or not, it's really depending on different insurance, but most of the time when they try to shy away from covering, it requires a lot of arguments and fight with them.
And Dr. Patrizio, I think my understanding is that it is covered if the person who's doing the genetic testing has a history of cancer. If they're a breast cancer survivor, would it, and they're found to have a BRCA mutation, would it then maybe be covered, or not necessarily?
Yeah, that can be easier to make the argument, because in the case where there is not, it's only a positive. Let's say that you have a incidental finding that there is a mutations and you are a carrier for it. If you are in the group of previvors, that is going to be probably much more difficult for them to act upon, them meaning insurance. I totally disagree with this approach that they take, because if we have to do preventative medicine, we need to do it, and it's very sad that they they try not to, try to be smart and not covering. I think they should, but it's much more difficult if we are talking about previvors.
And if there's any other questions, please feel free to enter them in the chat box. We have a few more minutes left. I'll ask another question, Dr. Patrizio. A lot of people are told that their children do not necessarily need genetic testing until they're age 25. And I think sometimes I wonder if people will want to have babies before they're 25. So maybe they do need to know. Do you have any thoughts on when children should have genetic testing?
I think this is I disagree with this approach of the 25, because like you correctly said, what if someone wants to have a child before that? But we are talking tonight about cancer gene screening. Remember that we're also offering additional type of screening that are not cancer related. We do a lot of expanded carrier screening for cystic fibrosis, spinal muscular atrophy, and so many more. So I foresee here an opportunity to make a case that whoever is trying to have is trying to reproduce, and particularly when you need to have some type of help or intervention to assist someone to have a baby, I think that it's not appropriate not to test. I think they should be offered the testing, and this 25 is a very artificial number. I don't know why they choose 25. I don't know who chose 25 for the cancer screening. Do you know who chose 25, Johanna?
I don't know. That's what a lot of patients tell me, that the genetic counselors, and maybe if there are any, I don't know if Claire's on, if Claire can sometimes can join in.
Can you hear me?
But I think yeah, Claire, join in, sure.
Hi, everybody. So the age 25 is when breast cancer screening starts. And I totally hear where you're coming from. There are people who would like to start their family before 25, and it is appropriate to have genetic testing before 25 in that case. The reason that we try and hold off on genetic testing for these young people is that we also have to balance the life insurance concerns and insurance discrimination concerns. So the best thing is to meet with a genetic counselor and really have that conversation, the balance of the pros and the cons of having testing. One of which might be the ability to do family planning before 25.
Yeah, thank you, Claire. And I think, again, it's all such a personalized approach depending on, the emotional readiness of the person being tested as well. So thank you, Claire. And we have one more question from Molly about how it can be overwhelming as a previvor to incorporate all this information from multiple specialists and make the best decisions about our care. Is there a clear process for the approach to care? Are there tools that can have integration from all the different specialists? And that's a great question.
Well,
Dr. Minkin, do you have any thoughts on that one?
I have a thought on everything. I have an opinion on everything. It may not be a thought, but it's an opinion on everything. Certainly, there are obviously high-risk specialists, as far as, for an example, in our department, from the GYN point of view, our program Discovery to Cure, I think that's the official title these days, Joanna, would be folks who are at increased risk, and people who are BRCA previvors and things like that would be seen there. And that would be sort of the primary counseling as far as prophylactic oophorectomies or oophorectomy and hysterectomy. And of course, there's the high-risk breast cancer clinic where the BRCA women are, given advice for breast surgery, medication surgery, things like that, as far as prevention there. We certainly, as SIMS, we like to see anybody who's having a prophylactic oophorectomy before she has her surgery. Okay, we like to talk with them and try to bring out, some of these issues to make sure they've thought about all these issues involved in the decision-making process, and also to counsel them in advance about things like hormone therapy. We really like to see these folks before surgery to maybe help them guide in some decisions about what kind of surgery might be interested in. Like, for example, decision uterus out, uterus in, that kind of decision that we can possibly give some advice on. And then certainly one of the reasons we like to see people before surgery, before they have their ovaries out, is that decisions on hormone therapy can be overwhelming to some young women because there's been so much propaganda in the United States that estrogen is poison, estrogen's bad for you, it's going to give you breast cancer. I am a breast cancer risk person, I can't take estrogen. And we would like to have time before surgery for women to discuss these issues with us to make decisions. And we'd like to be able to initiate estrogen therapy for women before they have a hot flash. That's our goal. We like to treat them before they start getting uncomfortable. And that's why we like to make these, again, we don't like to make the decision. We like to give them the information to let them make the decision that they feel comfortable with. We like them to have all that information before going through surgery. So, we like to be involved in giving some advice and giving some data and let them make the decisions, but before surgical interventions.
Yeah. And I think another thing is, patients can really get overwhelmed with appointments with all the different doctors, but, at least from my perspective is we all know each other. And I think, the second session of this webinar was with Dr. Hofstetter and Dr. Ratner, and we often talk to each other and say, well, Dr. Hofstetter, are you okay with birth control pills to prevent ovarian cancer? And she, for the most part, says yes. And we always talk back and forth about the decisions. And we always include an oncologist. If there's an oncologist in your, taking care of you as well, we always will include him or her in any of these decisions as well. So we do communicate. But if there's anything that we can do to help coordinate your care, I know that can sometimes be the challenging part. We're also happy to help. So we'll have one more question before we wrap up for tonight, and that's for you, Dr. Minkin. Anything to do for the memory loss that comes with menopause?
That's a hard one sometimes, okay. And cognitive issues, memory loss, that kind of thing, executive function, some people, put it under that category. And I think, first of all, the question is, are we talking about in somebody who's a previvor or who's a survivor? Because in previvors, I would say make sure they get some estrogen. Okay, it's somebody who's 45, who's had oophorectomy. If she's not taking estrogen, I would strongly encourage her to think about taking some estrogen because I think it can be quite helpful. If somebody is a survivor in whom we're not going to be able to give estrogen to, okay, then I think that we need to talk about things like possibility of using things like antidepressants, which can be helpful. And the other thing which can actually be helpful, and this is some work that was done here at Yale and has now been carried on at Penn in Colorado, places like that, are the use of drugs like the drugs for concentration, drugs for higher executive function, ADHD type drugs, which have been shown to be helpful for people without estrogen. So those are drugs that we can offer folks, which can be helpful. And the other thing, of course, that I'm really eager to find out is to see how the new NK3R drugs are going to be for that, because they act centrally. They're acting in the head. So I think some of the NK3Rs may be helpful for cognitive issues. But we don't know yet. We'll have to wait and see on that. But we do have things that we can offer.
Well, I want to thank you both, Dr. Patrizio and Dr. Minkin, for your time tonight and sharing some of your expertise with us and our panelists and our participants tonight. And again, this video will be posted on the Cancer Center website. So if anybody wants to share with their family members, the recording will be up soon. And thank you everybody for participating in this series. We had hoped to end with a meet and greet for our patients, which we might do in the future at some point. And if anybody wants to reach out and needs to get connected with somebody, I have patients who I can connect you with. And we're always here to help you. So reach out anytime. And thank you for watching tonight, and good night, everybody.
Anytime.
Thank you all. Thank you.
Thank you. Bye-bye.